Greetings. Hello, everybody. Welcome to Nova Southeastern University's South Florida Geriatrics Workforce Enhancement Program podcast, also known as the SFGWEP podcast. We're here to educate, encourage, and enhance our knowledge and skills and promote all those amazing health professional experts working with the elderly, including caregivers and interprofessional teams. My name is Naushira Pandya, and I'm Professor and Chair of the Department of Geriatrics at the Kiran C. Patel College of Osteopathic Medicine at Nova Southeastern University, as well as Project Director for the South Florida Geriatrics Workforce Enhancement Program. Nova Southeastern University appointed Dr. Stefanie LaManna as the Permanent Dean of the Ron and Kathy Assof's College of Nursing on July 31st, 2023. Dean LaManna, also an associate professor in the college, was named interim dean in March 2023. As interim dean, Dean LaManna worked to boost student enrollment and engagement by refreshing the curriculum, refining degree requirements, and expanding clinical experiences in both physical and virtual settings. Hello, Dr. LaManna. It's a great pleasure to welcome you to our SFGWEP podcast, and I wanted to thank you for your time and expertise.
Thank you, Dr. Pandya, for having me today. It's truly an honor and a privilege to be here to be able to speak about the passion that I have for nursing and the workforce.
And we're well aware of that. So I thought we could start by, if you could tell us what the future of the nursing workforce looks like and why is it important to you? And how has your experience been in training healthcare professionals and students?
So the nursing workforce, I've been a nurse practitioner for 23 years. I've been an RN for 30 years. I have an absolute passion for nursing, also to educate our future nurses. I feel that we don't prepare as well as we should in our geriatric workforce. Therefore, we have put in our curriculum throughout the nursing and nurse practitioner programs, geriatric caring, as well as taking care of patients in the geriatric workforce.
And we very much appreciate our collaboration with you.
I do have extensive experience in taking care of the geriatric population. I presently work in infectious disease, so a good portion of my patients are geriatrics. But not only do we have to take care of our patients, but we also have to take care of our families. And that is something that I have strived when refreshing the curriculum in education, is to put that in both the undergrad and the graduate nursing program of geriatric, how to take and what meds do they need, or how, or what chronic illnesses they encounter, which, can be different from someone who is younger than the elderly.
And they also present differently, and of course the patient does not come alone. They have a support system and a family that's usually involved, if they're fortunate.
They do, but sometimes it is unfortunate where I will tell you during COVID, the family caregivers could not come into the hospital at the time. So the nurses had to be the advocates, the physicians had to be the advocates for the geriatric population. As we move forward, and as we do move forward out of COVID, we have families by their side, but we also have to educate the families. And then sometimes there are no families for the patients. And sadly enough, they will be in nursing homes and they have no children. Spouse passed away. So again, it is up to us, nurses and physicians and healthcare providers, to understand and be able to take care of them appropriately.
And the care team does become the family in the end, especially in long-term care patients.
They become the advocates.
Do not have family.
Yep.
What is special about gerontology nursing?
For gerontology nursing, it is a special field. Hence the reason why we did put it in the curriculum, because it is different of taking care of adolescent as opposed to a geriatric patient. For chronic illnesses, they can get ill faster.
Indeed.
I will tell you, in the setting of infectious disease or in the setting of COVID, our elderly patients did get sick faster than our younger ones did, even with diabetes. Or you can go into dementia. They don't heal, like with diabetes and the chronic illnesses, they don't heal as well. So you have to take that special care in what you're prescribing. What I prescribe to an adolescent, I cannot prescribe to a geriatric. And I teach it this way too. When I look at pediatrics, I look at geriatrics. You almost have to treat them in the same manner.
A lot of similarities, and indeed, it's not just the medical management, right, of multiple chronic conditions, it's the management of their cognitive impairment, if that's there, or their functional impairment. They are not able to perform a lot of their daily activities of living, especially if they're sick.
Yes, and I say this, I said it before COVID, and I'll say it again after COVID. If we learned nothing from COVID, we learned how to work together as healthcare professionals, because our social workers, our physical therapists, our occupational therapists are key into helping our elderly patients to do their ADLs, to do their functional abilities, and dress themselves.
Read quite a bit about the decline in the nursing workforce, and I think that's a big priority for this country right now, is how to rebuild the nursing workforce. I understand that there was quite an exodus of the nursing workforce during and after COVID. There's studies like even 60% of nurses reported burnout, 75% reported experiencing a lot of stress and lack of support. So where do you think we're going in rebuilding the nursing workforce?
I had just actually done a presentation on this. So I will tell you, to back up a little bit, by 2035, we will be shortage in the state of Florida, 60,000 nurses and over 300,000 nationwide. So we are working diligently, hoping that our nurses will stay, because what we see in the hospital is that nurses don't stay for more than a year because of the burnout. COVID, we can backtrack to COVID. COVID played havoc on nurses, on physicians, on all healthcare providers. A lot of nurses at the time were either getting ready to retire, or maybe they were going to retire in 5 years. And I will just give an example of CVICU. In one of the hospitals, all the CVICU nurses are no longer there. It's all new nurses.
That's amazing.
So it played havoc. They got burnt out. I will tell you, some didn't make it. Some did pass away from COVID,
Of course,
being on the
there was
front
a
lines.
lot of loss of staff.
Yeah, and what we are doing now, and I've also said this prior to COVID and now that after COVID, is that academia and clinical partners need to work together. What we don't know in clinical, they do. What they don't know in academia, we do. We have started nurse residencies. We have been working with our clinical partners for nurse residency. So when they do get out of school and graduate, they can go into a nurse residency program.
Is that a new initiative, a nurse residency? I'm not familiar with that.
So it happened years ago, maybe 30 years ago when I started nursing. It has now become very much important in the past 3 years. I will say proudly enough that there are hospitals in Florida that have now a waiting list for nurses because they have started the nurse residency programs. How long that's going to last, I don't know, but we do need it.
Is that to enhance their skills, to
Yes.
empower them to work to their full scope of training?
It's all of the above. So it is, because you can throw the nurses to the wolves, right? But how are they going to learn? So if we nurture them, we mentor them, and then there are some hospitals that have actually started a nurse residency for years to build up their clinical skills, to build up their competence, feel a little bit more comfortable taking care of patients. But then after that, there's also a year fellowship. So if they wanted to go into ICU or they wanted to go into pediatrics or geriatrics, that they have that opportunity to further themselves.
It's really exciting news. So is that somehow related to initiatives by the American College of Nursing or the Bureau of Healthcare Workforce or the Elder Care Workforce Alliance?
All of it. So what happened is that, and I'll just briefly explain it, in the state of Florida, there is funding that the state had approved again this year, but it's called the line funding for the nonprofit schools. And the Department of Education is also involved in it. So you have to get a clinical partner that will donate money that will help with scholarships and help with education equipment. And then the DOE matches what the clinical partner gives you. And because of this, we were able to provide scholarships with clinical partners, and then they would have a position waiting for them, and also have education material that enable to enhance our education for nursing. And that way, when they go into the workforce, they're not as culturally shocked.
That's so important because before, and this may be me speaking from a long time experience, nurses would go from nursing school to various employment opportunities and really not be prepared. And if they weren't mentored by senior nurses or the medical staff, they just had to survive somehow and learn the skills on a day-to-day basis.
So I think we saw that before COVID again. And in my back days, yes. Now they're taking more of an initiative because of keeping our nursing workforce, because we do have a lot of nurses that retire and that are still going to retire as the years come, hence the reason why we are seeing that shortage of nursing. And there is a critical need of nursing.
It looks like there's several sides to this shortage. Lack of enrollment in nursing schools, and even an inadequate supply of nursing school faculty, which is so very important to training nurses to go out in the workforce, as well as more nurses reaching retirement age or taking on administrative positions. So I'm intrigued that the multiple factors here contributing to this shortage.
Yeah, and I will say that with the line funding I was just speaking about from the state and the Department of Education and our clinical partners, that was one of the reasons we are looking to help our faculty, because we do have a faculty shortage. And we know that in clinical practice, you do get paid more than you do in academia. So we are looking at those dollars for faculty, because if we don't have the faculty, we don't have the nurses. Who's going to teach the nurses? So we are looking at that as well.
It seems like almost a hybrid position where senior nurses acted as faculty and clinicians might work.
It will. And also the other things the hospitals are doing is that they are training their nurses to be preceptors and how to train them adequately. Because if you just jump in and say, I'm going to have you be a preceptor, well, what does that mean? So we have to train our trainers, and we did do that with the line funding. Last year, we trained our trainers on how to precept and be clinical adjuncts for our nurses to decrease, hopefully, the nursing workforce and make good nurses, and they don't leave the hospital bedside. The other thing I did want to add, too, is that geriatrics is very near and dear to me. So I see a lot in the hospital.
We love hearing that.
So we are threaded in our curriculum, both in the nurse practitioner, because you've spoken to our nurse practitioner students, and our undergraduate nursing, that geriatric and how to take care of the geriatric nursing workforce is paramount. With some of the money that we did get from the Department of Education, looking at simulation where it's professional, how do you speak to your patients, how do you take care of the geriatric, so it does encompass the soft communication. So we do have it threaded out.
So, Dr. LaManna, I may be old-fashioned and I've been around in the medical field for a long time, but I started my career working with nurses who were very familiar with the helping older adults with activities of daily living. Sitting them up, getting them up in the chair was routine, walking them to the bathroom, helping them with meals. Now, when I'm in an acute care setting, I see less of that. Things that seem so obvious to older clinicians don't seem to be happening. What is your take on that?
So like you, I'm old school. When I went into nursing school, we learned how to bathe our patients. And even to this day, I teach students that bathing your patient or even feeding your patient is the best way to do your assessment on the patient. That's how I learned old school. But there are times, and I will agree with you, the staffing sometimes is rough, where the nurses get to be so busy or they have an emergency and is still working in the hospital. I will walk in to a room with a patient, an elderly patient, and an elderly patient that does have dementia, or maybe an elderly patient that had broken their arm or had a stroke and can't feed themselves. And the tray will be sitting there and they haven't touched it. And then what happens is that the nurse or the CNA, the certified nurse assistant, will go in there and maybe take the tray away because they just felt maybe, the patient wasn't hungry. And that's where we are. And I will say during COVID and in the academics, because everything was virtual, I think we've missed that interaction and that communication with the patient. So old school that I am, I will feed the patient. And then I will bring the nurse in and discuss it with the nurse as to why actually this patient was left.
I agree with you. It's a basic need of the patient that has to be met by anybody in the healthcare team. And I say the same thing to residents and medical students. If you're sitting around, it's your job to help walk the patient. It's your job to set up the tray and help feed or set the patient up so that they can eat well by themselves. Those things are so basic and we tend to ignore them.
And same with you. So if I am on the weekends in the hospital and I see a student sitting down, whether it's a medical student or a nursing student, I take them in with me. And so let's this is the only way that you're going to learn, and then why it's important. Because if our patients don't eat and they're just left there and they don't get the nutrition and the protein, how are they going to heal?
They don't do well, and they lose weight post-hospitalization.
Yeah, and even being in the hospital, just for someone who is not elderly, somebody who doesn't have dementia, is still hard on them. And they can decline. So you can imagine, with someone who has dementia or Alzheimer's or the elderly, how much of a decline. And I do see that.
I take the example from one of the very famous physicians who talked about actual assessment and hands-on care of the patient, that we're kind of more involved with the computer and what the computer records tell us about the patient than the person in the room and what their actual needs are. So it's almost become like an eye patient. It's the patient is real in the computer, but nothing is real unless you're in the room and you assess the patient and decide what their needs really are.
I agree with you 100%. And I feel that I'll just say medicine in general. We know AI is going to be here. We know we have the technology that's going to be great, even in the homes of the elderly and people with the technology. But when it comes down to it, put that computer aside when you're talking to the patient, because it's all about the communication and the touch with the patient. And then you could do your charting after. You don't have to do your charting inside.
So, Dr. LaManna, I wanted to ask you, with the increased rates of dementia, do you feel that training nurses demands a different approach? How can we improve attitudes of the nursing workforce towards older adults with cognitive impairment?
I do agree, and yes, we do have in our curriculum on how to take care of elderly with dementia. I also feel for them to feel comfortable in a safe environment, because it could be scary, is to do simulation.
Very good idea.
With the students, and not only just nursing students. I think it needs to be with our medical students, our physical therapists. I think all of them working together need to have that type of training.
It would be a good module, wouldn't it, for a simulation program, a patient with behavioral and psychological symptoms related to dementia and how to approach that patient.
And how to recognize it at that.
Indeed. I'm always intrigued about, some of the outcomes. So nurses are burdened with a very high patient-to-nurse ratio. Apparently studies have really showed very poor outcomes, and I think we all intuitively know that hospital readmissions tend to increase, or surgical site infections, urinary tract infections increase, even higher mortality if the patient-to-nurse ratio is too high. What is your take on that?
So I will tell you, this is where nurses, healthcare providers, and all of us need to step in policy and advocacy. Mm-hmm. We need to write to our legislators and let them know of, what's actually going on. Speak to our nursing administrators and get on the same wavelength with them. But policy and advocacy plays a big part in this.
Yes, I think real examples are unbeatable when it comes to actually discussing how policy could change. And there has to be a level of communication, right, between the workforce on the floor of the hospital or the nursing home and the administration.
Yep. And this is where we do need to teach our students, interprofessional, on how to talk to our legislators, why it's important to get in touch with policy and advocacy, because it is for the quality of our patients. And that is the goal of all of this.
If you had one magic wish to make about the future of the nursing workforce in elder care in terms of research or clinical care or education, what would it be?
My magic wish would be that everyone understands how to take care of the elderly patients and what it entails to get involved in legislation and also to get involved in research. Because without research and bring it into the clinical practice, how would we move forward?
Yes, I think that's true, because having true data and data on outcomes is important, because that gives you ammunition to approach legislators, regulators, hospital administration. I think even data in terms of small quality improvement projects in the actual clinical sites is useful.
In nursing, we have a doctorate of nursing practice that works with quality improvement projects. And this is something that if I do have a wish, we are looking at the quality improvement of the elder population as well, which would be actually some good projects for our doctorate students to do.
Okay. What can we expect, do you think, in the future for the nursing workforce in elder care? I know you are involved in a lot of initiatives and you've given us some ideas already.
I wish, and what we can expect is that, and it's going to be up to, I say us, and academics as well as clinical, to teach our students and our new nurses and our nursing workforce how special care it is to take of the elderly population and what it means, and that they, they're just not put to the side.
No, I do agree. And if I can share my personal experience, I've felt that even when I was a medical student and a resident in England, I was mentored by many senior nurses who kept me out of trouble and being an inexperienced doctor and told me what was really needed, what I needed to order, what somebody, when somebody deteriorated, they would alert me. So I've always felt that we worked as a team and we covered each other. And the goal was the betterment of the patient.
Sure.
And sometimes I think in the professions here, we tend to work in silos. And there's not always good communication between nurses, nurse practitioners, physicians, specialists, as there could be.
So I will piggyback on that, and I will tell you I 100% agree. Coming from the clinical arena, we all have to work together because it is about the patient. I do feel that it starts from academics, though. We must have interprofessional education in order for our students to understand what it is like to work in the workforce and for the betterment of the patient.
No, I completely agree. Where can the audience find more resources on this whole topic of the nursing workforce in elder care?
There are professional organizations, the American Nurses Association, the Gerontological Advanced Practice Nurse Association, which I have to tell you I have looked into as well. I love that
I'm familiar with them.
Yep.
I've met several of them. I've spoken at some of their conferences.
Very good organization. The National Association of Geriatric Education Centers, again, are academic institutions, are governmental agencies, research journals, and our Elder Care Workforce Alliance and the American Geriatric Society.
Thank you so much. That is very helpful. And our Geriatrics Workforce Enhancement Program is one of the grant-funded programs that followed the Geriatric Education Center program. So there is a large emphasis on nursing education, especially in the long-term care setting. Any last thoughts for us?
I just honored to be able to discuss with you about the geriatric workforce and the nursing workforce in the geriatrics. And if I could just leave again, and I know I probably will reiterate this, is that how special the geriatric population is. So let's not put them aside.
Thank you so much for joining us today and sharing your experience with our audience. It's been a real pleasure to have this discussion with you. I know we've often talked informally about our interests and passions, but it's so great to record this and have you share your thoughts with us.
And thank you for having me and be able to share my passion with you.
Please stay tuned for upcoming topics from our renowned subject matter experts.